When Linda Carter told me this story, she made me promise never to use her real name. She's 53 now, living quietly in Portland, but back then she was a cardiac intensive care unit nurse at Massachusetts General Hospital in Boston. She'd been working in critical care for 17 years, starting as a med-surg nurse right out of nursing school, then advancing through the emergency department before settling into the cardiac ICU, where the most critically ill heart patients came to either stabilize or die. Linda was exceptional at her job. She had her CCRN certification, her ACLS, her PALS. She could read a rhythm strip faster than most of the residents. She could titrate vasopressors with precision, manage complex ventilator settings, and guide families through the worst moments of their lives with a calm, steady professionalism that made people trust her completely. In the cardiac ICU, you deal with life and death in measured quantities, milligrams of medications, millimeters of ST elevation on an EKG, minutes until the next code blue. Everything is monitored, recorded, documented, and explained by medical science. The unit itself was state-of-the-art technology. 12 beds arranged in a horseshoe pattern around the central nursing station, each patient bay separated by glass walls and sliding doors that allowed for both privacy and constant visual monitoring. Every bed had its own bank of sophisticated monitors, telemetry displaying continuous heart rhythms in real time, arterial lines showing beat-by-beat blood pressure measurements, pulse oximeters tracking oxygen saturation levels. The ventilators hummed and hissed their mechanical breathing patterns. 4 pumps beeped their programmed alerts. The whole place created a technological symphony that became white noise after your first few shifts, a constant backdrop to the serious work of keeping people alive. But what Linda told me about the night of March 14, 2019, is something that no amount of training, no sophisticated monitor, and no medical protocol could have prepared her for. It's the case that made her question everything she thought she understood about the precise moment when life transitions into death, and whether that transition is always as final and irreversible as medical science teaches us to believe. It started as a completely normal night shift. Linda clocked in at 7 p.m. for the standard 12-hour overnight rotation. She received her patient assignment from the day shift charge nurse during the standard bedside handoff report. She was assigned to bed 7, a 52-year-old male named Robert Sullivan, who'd been admitted to the unit 2 days earlier following an acute myocardial infarction, a massive heart attack that had nearly killed him. He'd been in full cardiac arrest when the EMS crew brought him through the emergency department doors. The code team had worked on him for 18 long minutes, doing chest compressions and shocking his heart repeatedly before finally getting a sustainable rhythm back. They'd rushed him immediately to the cardiac catheterization lab, where the interventional cardiologist had placed 3 stents in his severely blocked coronary arteries. The major problem was the prolonged downtime, 18 minutes without adequate blood flow and oxygen delivery to the brain. The consulting neurologist had performed an electroencephalogram that showed minimal organized brain activity. The family was now facing the impossible decision that no one ever wants to make. Robert was on a ventilator, heavily sedated with a continuous propofol infusion, his heart rhythm maintained and paced by a temporary pacemaker wire that had been threaded through his femoral vein. His wife and 2 adult daughters had been maintaining an almost constant vigil at his bedside since the moment he'd arrived at the hospital. Linda performed her standard initial nursing assessment at 7:15 p.m. She systematically checked all of his intravenous lines. He had 3 separate 4-access points running simultaneously, including 1 central line catheter inserted into his right subclavian vein for medication administration. She verified and documented his ventilator settings, assist control mode, respiratory rate set at 14 breaths per minute, tidal volume of 150 milliliters, fraction of inspired oxygen at 40%. She checked his arterial line catheter, which displayed a blood pressure reading of 118/64, acceptable numbers, being maintained by a continuous norepinephrine vasopressor infusion running at 8 micrograms per minute. His heart rate showed 72 beats per minute, fully pacemaker dependent. His oxygen saturation registered 96% on the monitor. Everything appeared stable and under control. It was textbook critical care management of a post-cardiac arrest patient with severe neurological compromise. The family had finally gone home around 6:30 p.m. to get some desperately needed rest and a proper meal. Linda felt relieved about their absence, not because she didn't care, but because it's always more difficult to perform your nursing duties efficiently when worried family members are watching and questioning your every move, though she completely understood their profound need to stay close to their dying loved one. The unit was relatively quiet that particular night. Only 8 of the 12 available beds were currently occupied with patients. 2 other experienced nurses were working the floor along with the charge nurse and 1 nursing assistant. Linda settled into her computer documentation station, methodically charting vital signs every 15 minutes as required by hospital protocol for critically unstable patients. At 8 p.m., she administered Robert's scheduled medications through his nasogastric feeding tube: pantoprazole for stress ulcer prevention, subcutaneous heparin for deep vein thrombosis prevention. She made a small adjustment to his propofol sedation drip to maintain appropriate unconsciousness levels based on his assessment. His pupils remained sluggish and dilated with minimal response to direct light stimulus. Not an encouraging sign for meaningful brain function recovery, but certainly not unexpected given his significant cardiac arrest history and prolonged resuscitation time. At 9:47 p.m., something changed in a way that Linda still cannot fully explain. She was seated at the central nursing station, carefully reviewing new laboratory results on the computer system, when she heard a sharp alarm tone emanating from bed 7. Equipment alarms weren't unusual at all. ICU monitoring alarms triggered constantly throughout every shift. Low oxygen levels, high airway pressures, disconnected electrode leads, empty IV bags. Experienced nurses quickly learned to distinguish the truly serious alarms from the routine nuisance alerts by recognizing specific patterns, tones, and pitch variations. This particular alarm was coming from the ventilator system. She immediately looked up at the large monitor bank that displayed real-time vital signs for all of her assigned patients simultaneously. Robert's oxygen saturation had dropped precipitously from 96% down to 88% in just a matter of seconds, a significant and concerning decline. She moved quickly and purposefully to his bedside. The ventilator display screen showed a high-pressure alarm warning, indicating that something was physically blocking or restricting the flow of air into his lungs. She checked the endotracheal breathing tube first, making absolutely certain it hadn't migrated out of position or become kinked somehow. The tube position looked appropriate. She systematically checked all the ventilator circuit tubing connections. No kinks visible, no accidental disconnections, but his oxygen saturation level was still dropping dangerously. 85%, 82%, continuing downward. Linda grabbed the manual resuscitation bag and began squeezing it to deliver assisted breaths while she continued troubleshooting the problem. The bag met significant resistance when she squeezed. Something was definitely obstructing his airway. She immediately paged the respiratory therapist stat and mentally prepared herself to reposition or potentially replace the endotracheal tube if that became necessary. That's precisely when she noticed Robert's eyes. They were open, not just partially cracked open. They were fully open, wide open, looking directly at her with clear focus. Patients on therapeutic propofol sedation simply don't open their eyes like that. The entire pharmacological purpose of the continuous medication drip is to keep them completely unconscious, totally unaware of their surroundings, unable to fight against the mechanical ventilator. Linda's immediate first thought was that somehow the sedation infusion had been accidentally interrupted or disconnected. She quickly checked the IV infusion pump. It was running properly and continuously, delivering 45 micrograms per kilogram per minute, flowing steadily through the patent intravenous line. She leaned over him, speaking clearly. "Mr. Sullivan, can you hear me? Blink if you understand me." His eyes tracked her movement with obvious intention, followed her face precisely as she moved to the side to check his pupil responses with her pen light, and then he deliberately blinked. Once, clearly purposeful and responsive. Linda felt her own heart rate accelerating. This should not be happening. This was pharmacologically impossible. She checked his sedation infusion line again. meticulously traced it from the electronic pump all the way down to the fourth catheter insertion site in his arm. Everything was properly connected. The medication was definitely, continuously infusing into his bloodstream. At that substantial dose, he should be profoundly, completely unconscious. The respiratory therapist arrived promptly, an experienced clinician named Tom, who'd worked at Mass General for 12 years. What have we got here? High pressure alarm, oxygen saturation dropped to 79%, and he's... Linda paused, knowing how absurd this would sound. He's awake. Tom looked at the monitor display, then looked down at Robert's face. On that much propofol? That's impossible. But Robert's eyes were unmistakably open, moving deliberately between both of them now, clearly tracking and following their positions and movements. His oxygen saturation had stabilized at 88% after Tom made some technical adjustments to the ventilator pressure settings, but the level wasn't climbing back toward the normal range. We need to increase his sedation significantly, Linda said with growing concern. I'm going to increase the propofol to 60 micrograms per kilogram. She made the dosage adjustment on the computerized pump. Within approximately 2 to 3 minutes, the vast majority of patients would show clear signs of deeper sedation taking effect. Eyes closing, progressive muscle relaxation throughout the body. Linda had witnessed this predictable response literally thousands of times throughout her career. Robert's eyes remained open, wide open, still watching them both intently. This doesn't make any medical sense, Tom said quietly, his professional concern obvious. You want me to page the anesthesia attending physician? Before Linda could formulate an answer, the cardiac monitor alarm began sounding urgently. She immediately looked up at the rhythm display screen. His heart rhythm had changed dramatically. The temporary pacemaker had been firing steadily and reliably at 72 beats per minute, with each electrical pacing spike followed by a normal QRS complex waveform, showing that the heart muscle was responding appropriately to the electrical stimulus. But now there were additional extra beats appearing. PVCS, premature ventricular contractions, then rapid runs of multiple PVCS, then sustained ventricular tachycardia, a life-threatening rhythm. Linda's extensive training took over immediately. Tom, call a code blue right now. She reached for the nearby crash cart while Tom ran quickly to the nursing station to activate the hospital-wide code blue emergency response system. Linda checked for a palpable pulse at Robert's carotid artery. It was present, rapid and thready and weak, but present. His blood pressure reading on the arterial line monitor showed 84/52 and dropping steadily. She mentally prepared to start aggressive chest compressions if he deteriorated into complete cardiac arrest. The specialized code team arrived within approximately 90 seconds. Dr. Mehta, the cardiology fellow on overnight call, immediately took charge of the resuscitation. Additional nurses from other hospital units flooded into the room, the respiratory therapy team, the hospital pharmacist, the ICU resident physician. It was controlled, organized chaos with every team member knowing their specific role and responsibilities. Give me a quick report, Dr. Mehta said while rapidly scanning all the monitoring displays. Linda provided the essential information in the clipped, efficient communication style of emergency code situations. 52-year-old male, status post massive MI with 18-minute arrest time, temporary pacemaker dependent, adequate sedation protocol being followed, developed acute high-pressure ventilator alarm, then symptomatic ventricular tachycardia with pulses present, blood pressure dropping progressively. Dr. Mehta carefully examined the rhythm strip printout. The ventricular tachycardia had spontaneously resolved on its own, converting back to normal paced rhythm. Blood pressure was gradually climbing back up. 92/58, 98/62, beginning to stabilize. Increase his sedation even more, Dr. Mehta ordered decisively, and let's get another electroencephalogram done immediately. Something significant is happening neurologically here. Linda increased the propofol infusion to 70 micrograms per kilogram per minute, well above the normal therapeutic range, approaching the dose ranges typically used for medically induced comas in specific situations. Robert's eyes stayed open, still watching everything, still tracking all movement in the room. And then, as impossible as it seemed, His right hand moved. Not a simple twitch or reflex, not an involuntary muscle spasm. His hand lifted deliberately off the bed surface, slowly and purposefully, and his fingers curled gradually into a loose fist. Linda saw it happen. So did Tom. So did Dr. Mehta. Multiple witnesses to an impossible event. Did he just voluntarily move? Tom asked, not finishing his thought. Dr. Mehta grabbed his penlight and performed a complete neurological assessment examination. Checked deep tendon reflexes systematically, performed a painful sternal rub to test for appropriate pain response. Robert's pupils reacted sluggishly to the direct light stimulus. His hand had returned to its resting position on the bed. No other voluntary movement was observed. "Get neurology down here immediately," Dr. Mehta said firmly. "And I want a stat CT scan of his head right now." The code team gradually dispersed to return to their regular duties. Within 20 minutes, they had transported Robert down to the radiology department CT scanner. Linda stayed with him during the entire transport, manually bagging him with the resuscitation bag while Tom managed the portable transport ventilator. The entire time during transport and scanning, Robert's eyes stayed open, remaining fixed directly on Linda's face. The CT imaging results came back completely normal. No acute stroke, no intracranial bleeding, no new structural brain damage beyond the original hypoxic injury from his prolonged cardiac arrest. Dr. Patel from the neurology service came to evaluate him around 11:30 p.m. She repeated the complete neurological examination, carefully reviewed the previous EEG from 2 days earlier, and ordered a new electroencephalogram to be performed at the bedside. His neurological exam findings don't match his apparent mental status at all, Dr. Patel said, frowning deeply at the extremely high propofol dose displayed on the infusion pump. At this level of sedation, he should be completely unresponsive to all stimuli. Yet he's clearly tracking visually, he's moving purposefully and voluntarily. This is extremely unusual and medically unexpected. The EEG technician carefully set up the sophisticated equipment, 21 individual electrodes placed systematically across Robert's scalp, each one recording electrical brain activity from different specific regions of the brain. The setup process took approximately 30 minutes. Linda watched the complex, squiggly wave lines appearing on the computer screen, looking for the recognizable patterns she'd learned to identify during her training. Normal alpha waves appear rhythmic and organized. Seizure activity appears chaotic and sharp. Brain death appears essentially flat with minimal activity. Robert's EEG showed something Linda had never seen before in her entire career. The waves were organized in pattern, but profoundly wrong. They displayed a clear pattern, but it wasn't any pattern that matched the extensive database of normal human brain activity. Dr. Patel stared intently at the screen for a prolonged time, scrolling back and forth repeatedly through the digital recording. "I need to consult immediately with my attending physician," she said finally, her confusion obvious. I honestly don't know what this represents." By 1 a.m., Robert's room had become the focal point of intense medical interest and discussion. 3 different neurologists stood gathered at his bedside, discussing the bizarre EEG results in hushed, concerned tones. The propofol was now running at 80 micrograms per kilogram per minute. Linda had never personally administered a dose that extraordinarily high to anyone who wasn't already brain dead. His eyes were still open, still tracking movements, still watching everyone. And then he attempted to speak. Not out loud, he couldn't possibly, with the rigid endotracheal breathing tube secured down his throat in between his vocal cords. But his lips moved deliberately, clearly forming words. Linda was positioned close enough to see clearly and read his lip movements. She leaned in closer, trying to read his lips accurately. "Help." That single word, completely unmistakable. Then his lips formed. "Can't leave." Linda felt her skin go cold. She looked up quickly at the neurologist. "Did you all see that?" Dr. Patel nodded slowly, clearly disturbed. "I saw it." One of the other consulting neurologists, an older physician named Dr. Rosenthal, pulled Linda aside privately. "Has anything remotely similar to this ever happened before on this unit?" "No, never. Nothing even close to this." Dr. Rosenthal's expression showed deep concern. I've been practicing clinical neurology for 32 years. I've seen locked-in syndrome. I've seen awareness during inadequate sedation. I've seen many unusual neurological presentations. But this, the bizarre EEG pattern, the extreme resistance to appropriate sedation, the purposeful, voluntary movement, I cannot explain it medically. What should we do? Linda asked. We continue appropriate supportive care. We monitor continuously, and we document absolutely everything in detail, because I guarantee someone will review this case very carefully later. At 2:15 a.m., Robert's heart rhythm became dangerously unstable again. More frequent PVCS than sustained ventricular tachycardia. This time his blood pressure crashed completely, 60/40, 52/38, then undetectable by the arterial line. Linda immediately started chest compressions. The code team returned quickly. They delivered electrical shocks once, twice, pushed epinephrine, pushed amiodarone through the IV lines. After 6 intense minutes of resuscitation, they finally achieved a sustainable rhythm. But throughout the entire time Linda was performing chest compressions, Robert's eyes stayed open, locked directly on her face with clear awareness. After the second code, Dr. Mehta made the difficult decision. We need to have a serious discussion with the family. This isn't medically sustainable. He's not showing any recovery. The question is whether we're just artificially prolonging the inevitable. Linda called Robert's wife at 3 a.m. The conversation was one of the most difficult she'd ever had in her career. Mrs. Sullivan and her daughters arrived at the hospital by 4 a.m., exhausted and terrified. Linda accompanied them to the private family consultation room where Dr. Mehta carefully explained the complete medical situation. The family made the heartbreaking decision to withdraw life-sustaining support. They wanted to be present. They wanted to say their goodbyes. At 5:30 a.m., with the family gathered closely around bed 7, the medical team began the withdrawal process. They deactivated the temporary pacemaker, turned off the norepinephrine vasopressor, reduced the ventilator support settings to minimal levels. The plan was to remove the breathing tube once his respiratory pattern became too irregular to sustain life. Linda stood positioned by the monitors, watching the vital signs decline. Heart rate dropping, 58, 52, 46. Blood pressure falling, 78/48, 64/40. Oxygen saturation declining, 91%, 86%, 79%. The family held his hands, whispered their final goodbyes through flowing tears. And then something happened that Linda still cannot explain, even now, 5 years later. Robert's eyes, which had been open and actively tracking for the past 7 hours, suddenly changed completely. The frantic quality disappeared entirely. His expression softened noticeably. He looked toward the corner of the room, not at his grieving family, not at the medical team, but at the empty corner near the window. His lips moved again. Linda read them clearly and unmistakably. "I see her," his wife gasped audibly. That's exactly what he always said about his mother. "I see her. She died when he was only 12 years old. He used to say he could still see her sometimes, watching over him." Robert's heart rate was 34 now, blood pressure 52/30. The monitor alarm was creating a continuous tone that the team had compassionately muted to give the family peace. His gaze remained absolutely fixed on that empty corner. And then for just a brief moment, Linda could swear she saw something there. Not a distinct figure exactly, more like a subtle distortion in the air itself. A shimmer, like heat waves rising from hot pavement on a summer day. Robert took his final breath at 5:47 a.m. His heart rate dropped to 0. The cardiac monitor showed a completely flat line, but his eyes stayed open for another full minute, still looking at that corner, still seeming to see something none of them could see. When Linda finally reached up to gently close his eyes, his body was still warm, and she could have sworn, though she knows how irrational it sounds, that for just a second, she felt a distinct warmth in that empty corner of the room, like someone standing there, watching over him. The family stayed for another hour. Linda cleaned and prepared Robert's body according to standard hospital protocol. She documented everything in the electronic medical record, though she deliberately left out the parts that had absolutely no medical explanation. The EEG results were filed with a note from Dr. Patel. Highly unusual pattern, requires further research and peer review. Linda's shift ended at 7 a.m. She gave detailed report to the incoming day shift nurse and drove home. She didn't sleep at all. She kept seeing Robert's eyes, kept seeing his lips form those words. Can't leave. I see her. Over the following week, Linda conducted some research. She talked extensively with the hospital chaplain, who told her that unusual awareness at the moment of death isn't nearly as rare as people think. She talked with a hospice nurse who'd worked in end-of-life care for 20 years, who shared multiple stories of dying patients describing visitors that no one else could observe. But then Linda discovered something in the hospital electronic records that made her blood run cold. She was reviewing past cases, searching for any similar presentations, and she found one, a patient from 8 months earlier. Different room initially, different primary diagnosis. An elderly woman who'd suffered a massive stroke and was being withdrawn from life support. The neurologist's notes specifically described unusual awareness despite adequate sedation, and patient appeared to be watching something in the room that staff could not observe. That patient had died in bed 7, the exact same bed where Robert Sullivan had been. Linda pulled up the electronic records for every single death that had occurred in bed 7 over the past 3 years. Most were completely unremarkable, standard ICU deaths with expected clinical courses, but 4 cases stood out distinctly. All of them specifically noted unusual awareness at the end. All of them described patients watching something or someone invisible to medical staff. And in 3 of those 4 cases, family members specifically mentioned that the patient had a history of claiming to see deceased relatives during their lifetime. Linda brought this disturbing pattern to the attention of the charge nurse, who brought it to the nurse manager, who brought it to hospital administration. A formal investigation was quietly launched. They checked extensively for environmental factors, carbon monoxide levels, electrical issues, anything that might cause hallucinations or neurological symptoms. They found nothing. They brought in specialized equipment to check for electromagnetic fields, infrasound, anything that might explain the phenomenon. They found nothing. The investigation quietly concluded with no official findings. The hospital's official position was that these were coincidences, likely the result of confirmation bias and the intense emotions naturally surrounding end-of-life care. But they closed bed 7 for renovations that lasted 3 months. When it reopened, it was in a completely different configuration, moved to a different physical position in the unit. Linda requested a transfer 6 months after the incident with Robert Sullivan. She told her manager she needed a change of pace, wanted to try something different. She moved to a general medical floor, then eventually to an outpatient cardiology clinic where the patients were stable and nobody ever died. She hasn't worked a single ICU night shift since that night. Linda still thinks about Robert constantly, about those eyes watching something she couldn't see, about his lips forming those final words. I see her. She thinks about the shimmer in the corner of the room, the warmth she felt there. She wonders if the line between life and death is as clear as medical science teaches. If maybe in those final moments, people can perceive something that exists just beyond what we can measure with our equipment and our science. She'll never know for certain, but she knows what she saw, she knows what she felt, and she knows she can never go back. If you've ever worked in healthcare and witnessed something you can't explain, I'd like to hear about it in the comments. Subscribe if you want to hear more stories like this, the ones that don't make it into official records, because some stories never really end. They just find new witnesses.